lamellar is partial thickness, and nowadays there's deep lamellar, there is lamellar, so different kind of lamellar, and penetrating is full thickness, which is the most optically yielding kind of transplant. We have different types of indications. You have optical indications, tectonic, therapeutic, and cosmetic. So optical, we know what does that mean. It's self-explanatory. It's to give the patient better vision, either by removing a scar, removing abnormally curved cornea, and get a better optics for the patient. Tectonic, okay, is when you are removing, okay, cornea because you are worried about it perforating. Okay, so you are doing it to restore the shape or maintain the consistency of the eye. Right? You've heard about patch. And what is a patch?
Just a piece of cornea. Just a piece of cornea where there's nothing.
So what's the difference between patch and tectonic? Yes. And patch, you don't remove the cornea. It's like a patch, like a plaster. So on top of the diseased cornea, you put another cornea. Okay, and this is to, again, stop the perforation or pending perforation, but why you're doing patch and not tectonic?
Because you're planning for tectonic.
No, because you cannot remove the cornea. It's just too thick, too melting. You can't get smushy. You know, you can't just cut it and put another one. Where would you suture it? So you're just patching on top of it another extra thickness or volume. Okay, I've done it once. Okay, and never again. But it is done, and it is sometimes required. Okay, tectonic, as we said, to help the eye, stop the eye from perforating. Therapeutic, we just discussed it in details now. It's when you want to remove the pathology, the infection, okay, and put another less cornea loaded with less bacteria. So you are reducing the volume or of the packaging. Okay, that's when therapeutic is done. Cosmetic, if patients have a scarring and they want. I had a recently patient who counseled me for cosmetic transplant. Okay, the problem is if the scar is only, and why would you call it cosmetic and not optical? Because there is no potential vision. Okay, there is not much patient is hoping to gain vision from. So if the corneal scar is total, there is no point in making the eye look like normal black in the center and white frame. What's the difference? So it's only if the scar is central, where you have a clear bed that you can suture, that will give him the best results, then you can consider cosmetic. Because leaving a patient blind with a painless eye is better than converting him to blind with a painful eye. If he rejects, or he develops inflammation or all the other possible complications of transplant, then he was, you know, not nice looking but pain free, and now he's not nice looking but with pain. Okay, so always consider these things when you are preparing the patient. Donor tissue has to be removed within 6 hours after death. Okay, it can remain viable for 14 days. Okay, in Optisol, and nowadays even longer in tissue media. We don't get those; it's only in certain banks. You don't take cornea if you don't know the cause of death, or there is infections of the CNS, or there is systemic infections. There is history of leukemia or disseminated lymphoma, or intrinsic eye disease. So if you don't take corneas from these patients as a donor. Okay. Now, what are the risk factors for rejection? You can reject the cornea, okay, for many reasons, either coming from the donor or coming from the recipient. So let's go over them briefly because you can be asked these questions. Okay, in the patient, if there is absence of corneal sensation, it may affect the healing of the cornea. So they may have persistent epithelial defect, neurotrophic ulceration, inflammation, and rejection. Okay, so always patients post-herpetic eye disease, when you counsel them for transplant, you tell them 2 things. Actually 3. corneal transplant patient develop glaucoma. So if they have a herpetic eye disease, they're more likely to develop it. Okay? And mind you, the intraocular, the inflammatory process that could have been associated. Okay? What you need to know is eyes or corneas that undergo or subject of any inflammatory process, okay, anytime, even 20 years ago, is no longer the normal cornea because something called the immune privilege is lost. It's only immune privilege as long as it hasn't been touched by inflammation. Once it's been touched by inflammation of any sort, this immune privilege is changed, and there are the antigen presenting cells are permanently residing in the cornea. Now, 20 years down the road. Okay, so although we say that the cornea is immune privileged, that's why rejection, we don't need HLA matching, no neither blood grouping, but you still have rejection. Because you lose the immune privilege because of any incidence of inflammation in the past. Right. Presence of active inflammation is contraindication. Okay? And corneal thinning. Okay? This is very tricky when we are transplanting keratoconus patients with very peripheral thin corneas. How far can you go? You have to stay away from the limbus. Why? Because the limbus is where the vascularization comes from. So if the cone is very inferior and the cornea is really thin and you really have to get the thickness in order to suture the cornea very close to the periphery, you are at risk of. We do it because they have no other choice. We do it, but you have to worry about this rejection. Plus the keratoconus patients are young. The younger you are, and the older the donor, so the younger the recipient, the older the donor, the more likely that you will reject. Now, when we talk about complication, okay, you have to divide your thoughts into intraoperative. You discuss the risk factors, fine. Okay, these can be a risk of complication, but not for the surgery itself. Now we talk about intraoperative, postoperative. Postoperative can be early postoperative and delayed postoperative. Okay, so the early complication, you can have that chamber, resistant epithelial defect, and infection. Let's talk about the epithelial defect. What do you know about epithelium in donor?
Yeah, already lost.
Ideally, I try to receive my corneas before the 10th day of death. So I transplant them at day 8 or day 9. Okay, and in many of these cases, the cornea hasn't sloughed yet. The epithelium hasn't sloughed. Beyond 10 days, most of the epithelium is sloughed. The unsloughed epithelium has two scenarios. Okay, you will transplant the patient, next day, wow, no epithelial defect. Wonderful. Day 2, total epithelial defect. It's sloughed while it's on the patient. It's better to slough than to stay. Because if it sloughs, the risk of rejection is less. Because then the patient, the recipient, will draw his own epithelium and cover the defect. Understand? So it will be his own epithelium. Where if it remains as the donor epithelium, for some time, eventually it gets replaced gradually. But during its stay and replacement, there is a risk of rejection. It's aggressive. You don't want to touch those patients. You will understand. So late complication include glaucoma. 40% can develop glaucoma. Why? They ask you why. Why would a transplant patient develop glaucoma? Steroid induced. So how long it takes you before you get the steroid induced glaucoma? 3 weeks. 3 weeks. We need 2 to 3 weeks. Before that, it's not steroid induced. Okay. Anything else you can think of? What else?
Previous inflammation.
Previous inflammation with the presence of synetia. Large graft causes distortion of the angle during suturing. Okay, so these things you can think of. Right. Wound separation. System with trauma usually, but it can happen after 1 year when you are removing the sutures. It can actually open up. Cystoid macular edema, like any other intraocular surgery, and recurrence of the initial disease. Now, I need you to understand another concept in corneal transplant. The difference between graft failure and graft rejection. And the difference between primary graft failure and secondary
it's less than.
So from day one, you don't have a clear cornea. So your cornea is edematous from day one and never cleared. No pain, no inflammation, no injection, nothing. Okay? So this is a differentiation. Okay? I see many cases diagnosed as corneal graft rejection pumped with steroids, and actually it's only graft failure. And failure is because of the endothelium dysfunction, either primary because the donor didn't have enough, or as she said, it's been manipulated aggressively, or secondary failure, which the endothelium was okay, but at the borderline, and then it started dying very fast, so you lost its clarity. And these are difficult to differentiate in terms of rejection. But look at signs of inflammation. No sign of inflammation, don't tell me rejection. Okay? White eye, edematous cornea, no KPs, no anterior chamber reaction, nothing. It's failure. Secondary endothelial failure. Types of rejections, okay, and their features and management. So, let's talk about that. We'll go to that. This is extensive on surgical procedure, not for the purpose of the lecture today. More for your exam orientation. Let me know if it's your lunchtime and I need to stop. We started 15 minutes late, so I have the right to give you 15 minutes.
15 minutes.
Okay. But if you want to stop anytime, please. Okay. So let's talk about corneal graft rejection. Again, another common area of questioning in the exam in the cornea station. They will either show you an image of a corneal transplant, ask you to recognize the surgical procedure. They may give you a little history, ask you for indication. We talked about indication types of grafts, optical versus tectonic versus therapeutic versus patch. You should know now by this stage. And then we will talk about rejection. Patient had a corneal graft transplanted 5 days ago. Comes with pain. Could it be a rejection? You need a minimum of 2 weeks for the inflammation and rejection to take place. Step early is usual. So know your time frame. Okay, 2 weeks onward is a risk of rejection. Patient presents usually with pain, decreased vision, inflammatory signs in the eye, which could be, can anyone tell me? Yes, reduced eye. There's different type of eye rejection, epithelial stroma and endothelial. So we talk about either one. Any of them have anterior chamber reaction. Okay, catetus line is more of an endothelial rejection, and then calyx. Okay, epithelium irregularities is more for the epithelium. Stromal rejection can be of 2 types. One that is not very aggressive, not necrotizing, and they are progressive edema, and it's actually marks the upcoming endothelial rejection. Okay, or it could be necrotizing, aggressive. Okay, whitening, melting of the stroma with severe inflammation. So it could be either the stroma rejection. So let's go over. Here I'm trying to show you the linear, okay, the position of keratic precipitates. 35-old male, okay, presented with redness, pain, decreased vision, his right eye for 5 days. The patient previously underwent penetrating keratoplasty in the same eye 15 months ago. 2 months prior, his vision measured 20/40 right eye, and he was using Fred 40 and cyclosporine eye how do you treat this patient?
Everyone knows steroids.
Okay. Oral or IV? Topical or systemic? Okay. So this is what you need to say. Okay. First of all, this patient needs an admission. Okay. You need to exclude any risk factor or a contraindication for use of steroids. Okay. What if the patient has a pneumonia and you give him methylprednisolone and he dies next day? So you have to, you see, the examiners wants to know that you are an actor and you know how to act. So you need to play them also this kind of game. Okay, I will admit the patient, I will exclude since with steroids. So you need also. Then what you will do is, now let's talk about topical versus systemic versus oral versus IV. Okay? It's all in the literature, it's all in your books, there's many papers on it, but this is what you need to know. Topical steroid is a must. Hourly, aggressive. Okay, so you have to be aggressive, hit the patient hard. Okay, with hourly topical steroids, the maximum strength you have, which is the PRED 41% round the clock. So you're done with your topical part. Cycloplegic, the patient is in pain. Right? Number 2 comes to the systemic. Systemic is, in this kind of category, is a must. Okay? Whether it's IV or oral, there hasn't been a lot in the literature to prove that there is IV is preferred or oral. Both can do the same job. Okay? It depends on the severity. I, as an ophthalmologist, I would decide. Such an ugly case, I would like to start with IV for 3 days and then switch the patient to oral. Okay? And then monitor their response accordingly. And when I switch them to oral, it's going to be 1 milligram per kg per patient. Okay? And then I will taper according to, sometimes I taper every 3 days by 10, and sometimes I taper 5 weekly. Depends on how bad, okay, is the patient's situation or response. So, or topical, systemic can be oral or can be IV, preferably IV if you have access, it gives a better. If you pick up the patients and treat them within, well, I would say 5 days, but 48 hours of the initial episode, you can reverse it, 100%. Most of the patients I treated within 48 hours of rejection episode are reversed. Those that comes after 5 days or 1 week, they take longer time. You may reverse the rejection episode, but then you can have subsequent damage, which is you can have scarring, you can have endothelial, secondary endothelial. So you can treat the rejection, the inflammation has gone, no redness, no pain, no cavities, no lines, everything is clear, but the patient for is still epilepsy. You have to be able to differentiate. Now I'm not dealing with the rejection inflammatory episode, I'm dealing with the secondary endothelial failure, which happens secondary to that rejection episode. Something you have to have. Right. Okay. Let's see his examination. This is how he looked before the transplant. So he was a keratoconus patient, which we'll go through another lecture shortly. So in corneal graft rejection, we know all the symptoms. We discussed it. Differential diagnosis, you have to rule out other causes of such presentation, like uveitis, suture abscess, infection, recurrent disease of the graft, but everything will have its own clinical signs. We start with the steroids, as we said, okay, systemic, oral, or IV. So what is a rejection? It's an immunological response, okay, and it should be made in the grafts that have remained clear for at least 2 weeks following. So you have to have a clear graft for 2 weeks, then you can follow the rejection. If it's not clear from day 1, it's a primary endothelial failure. Okay, we don't need this slide, and we know the findings, risk factors, age of the donor and recipient. The younger patients are more prone to develop rejection because they have more active immune response. Okay, and donors more than 50 also has higher risk for being rejected. Why? They live long enough to have the immune cells in their cornea. Other risk factors, the presence of herpes, uveitis. Okay, if there is a iridocorneal touch, usually if it's more than one quadrant, I don't transplant because I know the prognosis is poor. Okay, the presence of silicone oil or its keratoplasty, previously failed graft. If you have a graft that fails, what is the risk of rejecting or failing the second? If it's a primary endothelial failure, it's your luck. You can take another chance. But if it's a rejection, it doubles actually. Doubles. You can have double the risk of previous. Okay. Now blood transfusion. Pay attention here. I didn't say blood group. I don't care about that. Okay? But if you have a blood transfusion, you can have risk of rejection of your graft. But not about your blood group and the donor's blood group. They proved recently in the literature that it has no value. Whether I'm an A and B and O, doesn't matter. It has no effect on the outcome of the court. Yes. Okay. Other risk factor, eccentricity or large grafts, proximity to the limbus. Okay. And we know why. And then they talked about the donor epithelium. Okay, because they have higher concentration of HLA antigen in the epithelium. So if they don't slough it, they keep it, they have higher risk. Eccentric grafts. Sometimes we do eccentric grafts in keratoconus. Let's say I have a patient with an inferior cone. Okay, it's not central, but I don't want to make a very large graft. If I want to include the whole cone and make it central, it has to be 9.5 to 10, which is very big. Okay, but I can decenter it a little bit so that my suture it doesn't touch the pupil. At the same time, it is small and include the cone. So this is called eccentric or recess because it's again closer to the limbs. Right. Corneal vascularization, we know it's a risk factor. Okay. But which one is more risky? Stromal or epithelial? Because you can see a lot of patients, contact lens wearers, keratoconus, they come for transplant and they have epithelial, superficial pans. It's not the risk factor. Okay, the risk factor is the stromal vascularization. Okay, and this is what I told you about the immune privilege, that it gets lost because of the antigen presenting cells. 69% survival at 7 years in most of the transplants. If you are to choose a donor, okay, let's say you open the web page of the bank and you are to select your corneal graft for your patient. My patient is 24 years old, and I see that there was a 57 years old who died 5 days ago, or 3 days ago. By the time I get it, it will be less than 10 days. Endothelial count of 2,700. And then I have another 24 years old, it's matched by the age of the patient, and endothelium of 2,200. Which one you will go for? So you go by age or by endothelium? Some people say A, some people you go by endothelium. Age no longer matters. Okay, although I said it's a risk for rejection, but I prefer to take the entire endothelium because I need this cornea to survive longer in my patient. So I will take the cornea age, not the patient age. Cornea age is by endothelium. So if I have 2,700 endothelium, I'll take it over that 2,200. Okay. Now, epithelial rejection happens in 2%. Okay. Usually happens at the periphery and proceed to the center. Why? Why you have these corneal whorls or verticillata in Fabry's disease and amyloid toxicity? Why they are whorls?
Because they're almost
Yeah, and why do you see them? Is migration unusual for the epithelium? All the time. So why do you see them? Because they are not clear anymore. It's like now they are carrying a flag. They're moving every day, but today they have a flag, either of amyloid or Fabry's disease or rejection. Okay, so they become visible. They became visible suddenly. So you see them in a typical of the world or verticillata. injection is what we discussed also. That's not the real images. You can see, maybe if we dim the light. Okay. We talked about the Keratoplasty line and the other features. And here it is actually being shown. Similar to that one, but it can be subtle. Okay. See here. We will not be very mean. We won't show you such a slide, but we may. Again, what am I showing here? There is line and a graph. So put things together. She's showing me a graph. There is a line. She must be showing this line. What else could it be? Okay. So management, we talked about that, and we said the earlier you treat them, the more likely for you to reverse. And we talked about why you have a problem with intraocular pressure. Sometimes I put them on immunosuppressive therapy and selective cases. We tried anti-VEGF injections, subconjunctival anti-VEGF injections to promote or optimize. Okay, but I had very most of the vascularization occurred. Like I gave in some patients 7 injections, and I gave in patients 3 injections, another 12. But all of them at the end of the road, once you stop the injection, the vascularization comes back. This is a minor cohort, but it can be useful anti-VEGF. Okay, so management of corneal graft rejection consists of early detection, aggressive therapy. Corticosteroids is the mainstay of therapy, and immunosuppressive can be added, and you have to identify and counsel the patient. If you properly select your patients and counsel your patients, you will have very low incidence of, I don't say you won't buy the wool, but like it, you can always be selective with your patients. Any questions? I will not talk about immunogenicity, it's too much, and tissue matching. This is very important study, the collaborative organ transplantation studies. Okay, you can read it, it gives you various. I have a small, very useful article. Unfortunately, I don't have a soft copy, so I gave it to she will make a photocopy and a summary of what you need to know